All right, so let's continue on with our talk about evidence-based nursing practice. So some models that have been used for evidence-based nursing practice, there are dozens of them. The three we have listed here are pretty widely used. The Iowa model is what this book bases a lot of its stuff off of. When I taught this course before with our students, we used the A-STAR model of knowledge transformation. So like I said, there's many different kinds you can use. So you just have to select what works best for you and what you're looking at the time. So So as far as individual nursing practice, we're, as you know, especially you RN to BSN students for sure know that you have to make decisions and give advice on a daily basis. I mean, especially if you're, well, anywhere you are. I've worked home health and acute care and constantly are teaching and updating your patients. And I know at TMC a big push now is we teach side effects constantly. And we have this M in the box, which any new medication, we put an M in a box on their whiteboard, and that reminds everyone to teach on that medication. And so we're constantly being required to do those things. So there's a lot of clinical scenarios that, give us an opportunity to practice evidence-based practice and not just give advice based on what we've experienced in the past or what someone else told us or what we learned in our textbook, but to actually give advice based on best practices. So there's a couple of questions here. Is there a reliable screening tool for assessing risk of C. diff among surgical patients? That's an opportunity if you have that question and don't know. That'd be an opportunity to look for evidence-based practice or clinical guidelines on those things. Are there ways to reduce pain of children undergoing allergy scratch test? That's a way, outside of acute care that we could use evidence-based practice to see if there was something we could do there. So when you decide to take on evidence-based practice, there are some major steps that you go through. So the first thing, of course, and you read the article in week 1 about having a spirit of inquiry. So you just ask questions that reflect uncertainties. So, if a patient comes up with something that is new to you and you don't know, perfect opportunity to start looking at evidence-based practice. And I can even say for myself in practice, that's not always the first place my mind goes is, I should look that up and figure out, what's the best, what's best practice in that question, because I don't know. I know what I would do. I know what, the old wives' tale my mom told me to do, those kind of things, but I may not know what best practice is. So after you ask the question, then you start looking for evidence. So you search out the evidence and assemble it, and then you start appraising it and synthesizing it. So that's looking at, is this good evidence? We've talked about the ways to do that. Is this good evidence? And then putting those things together, the good studies together, and comparing and contrasting. And then you'll integrate evidence with other sources. So your clinical expertise is one other source. The patient preference is another source, because this is where, like I said, you're really qualitative, but everybody is different. And so you need to look at their preferences on things. And then also your local context. So if a study was done in inner city New York City, it might not be applicable here in rural Oklahoma. So you need to look at that context of the culture and where you're practicing. And then you need to assess the effectiveness of the decision or advice or intervention, whatever it is that you end up doing. Was that effective? So asking the clinical question, that's where you start. And as you guys know, you may not have known what PICO stood for, but now you will. Later on in the semester a little bit, we have an actual assignment where you'll write PICO questions. And once you start working on them, they're not that hard. They seem a little intimidating at first, but they're laid out very similar for each question, and they're not super hard to come up with. So what we're looking at when you're writing a PICO question is the population you're addressing. So who are the people that you're asking the question about? And then the intervention, what are you going to do? What's going to happen? Comparison you may or may not use. So if you're comparing one type of treatment to another, then you might do that. But you might just say, what happens if you do this? And so you leave out the comparison in that one. And then your outcome. You want to predict, so you're kind of writing a hypothesis. So you're wanting to predict what the outcome will be. And then the time. And that is sometimes specified and sometimes not. So it just depends on if it's relevant for that question. So templates, like I said, in your assignment, you'll have a template like this. And this makes it a lot easier. So it can really help with your wording. And I would use these from now on. If you ever have to write clinical questions again, use templates like this, because like I said, it takes the guesswork out of it and you know you'll have a good question. So for an example, you could say for your population patients with a central line, because we've talked about CLABSI here, what is the effect of cleaning the port with chlorhexidine in comparison to cleaning the port with betadine on your outcome would be the incidence of CLABSI. So you have a question there. That's the basis for you to set up the study or to find the information that goes along with that question. So when you have your information and you're looking at appraising the evidence, and like I said, all of this stuff, we're kind of hitting it really lightly, and then this is what we're going to be getting into as we start working on our projects and working through these chapters. So first of all, you're going to look at what's the quality of the evidence. Was the study rigorous? Is this a good study? And like we talked about in the hierarchy, it may be really high up, but if the study was poorly done, then it's not good quality and you can't use that as evidence. And then we get into these weirdly worded things, like what is the magnitude of the effects? And this is basically saying, is the study clinically important? Is this something that's going to make a difference or not? And I can tell you, being in doctoral studies, that's a huge question, because everything I want to write about, they're like, so what? That's their favorite question is, so what? Why do I care about this? So you want to make sure that it's something that actually matters, that's going to make a difference in something. How precise are the estimates of effects? And this gets back to quantitative, how good is the data? And so that gets a little deep. Is there evidence of side effects or peripheral effects is what they're called. So this is looking at the benefit or the cost of the evidence, and not the cost financially on this question, but the cost of the patient. So for example, like you could talk about quality of life or comfort or actual side effects of a certain treatment. And so how does it weigh out is what you're asking here. And then what are the costs, the financial costs? And I know we don't want to talk about this, but everything is money driven. So if the hospital cannot implement the intervention and suck up paying for whatever is going wrong, and it would save them money, they're probably going to do that. Now, as we've seen with CLABSI and CAUTI, the cost of the incidence of that happening, of having a UTI or a bloodstream infection, are so high that it's worth them putting these bundles together and looking for the best evidence and getting the cost down and saving people. But it does a lot of times with organizations come down to money. And then clinical relevance. So when you're in practice, is this relevant for your patient in your setting? And so, like I said, rural Oklahoma may be a little different from a lot of the studies we look at. And so you need to make sure that it's relevant and applicable to what you're doing. So as far as integrating evidence, you have to take evidence-based practice, and you can't just take, this is the best evidence, this is the way I'm doing it, I don't care what else is going on. You have to use your own clinical judgment. So it's not like you could not critically think as long as you have the evidence in front of you. You still have to critically think. You still have to use your knowledge because, and I'm kind of jumping ahead, but like we said, everybody is individual and not everyone reacts the same way to everything. And those of you who are in practice know that. So it's not always going to work to use this just straight out, no questions asked. So if you're a really black and white person, this is the way it has to be. it'll be hard for you to know that this is best evidence, but in this situation it's not. So, and also looking at patient preferences and values. So we know if somebody has a hemoglobin of 3, the best practice is to give them some packed red blood cells. But if that patient is, I just totally lost the religion, but Jehovah's Witness, they are not allowed to take blood from someone else. So, and I had a patient like this once, and so we had to try to manage, give her iron, do other things to build her up besides give her blood. It was kind of scary to me. But even though we know what best practice is, her preferences and her values kept us from being able to do what that best practice was. So we had to modify what we were doing. And then look at evidence from qualitative research. And like I said, this looks at that individual, the differences and how people feel about things and how this, how this affects the client situation or the clinical situation in a softer way, if we're okay with that word. So as far as evidence-based practice in an organizational contact, you're going to want to, what they'll do is select a problem. And there's 2 different ways you can do that. You can have something that happens in clinical and you're like, I don't know how to do this. I don't know how to deal with this. And like I spoke to you guys about at TMC with the increased incident of CLABSI. That was a troubling clinical situation. What do we do? Our incidence of CLABSI went up. And so that problem-focused trigger caused them to start looking at best practice, looking at what they were doing, and realized that the dressing was wrong, and they changed that, and it was fixed. A knowledge-focused trigger is just recognizing something in research findings and saying, hey, we should try that here. I think that will help patient outcomes. I think that will. So it doesn't really start with the necessarily problem, but it starts with finding something that you think would work better. So in an organizational context, again, you have to be able to look and see, can this be implemented? Is it transferable out of this one little pilot area that we're going to do it to other units? Is it feasible for us to do this? And then again, we come back to the money. Is it cost-benefit ratio? Is what it's going to cost us, we're going to make up for that and how it benefits us. And so in an organization, you're going to probably set up a pilot on one unit. And if you're changing, say, the little caps that go on IV tubing, and you're going to start using those, say, and you haven't in the past. So what you'll do is start with one unit, and you'll plan how this is all going to look, how we're going to use it. You'll educate the nurses about it before you roll it out, and then you roll it out, you do it, and then while that unit starts it, you're going to be checking all the time and studying and seeing if that works. And then you're going to go to the act. This is called a PDCA, or Plan, Do, Check, Act cycle. So you're going to change what you're doing based on, okay, was that effective or was that not effective? And you can modify it a little bit and do it on a small scale before you roll it out to the entire organization. So it's a way to kind of do a mini study within your hospital to see if that's working for you before you roll it out. All right, so you've got 2 videos, a little bit less than 30 minutes altogether for Chapter 2. And I hope that you guys can watch these and kind of get an understanding of this chapter before we meet on week 3. And for you RN to BS centers, I will see you guys online. Thank you, guys.